External monitoring methods are non-invasive and do not require rupture of membranes. When monitoring uterine contractions, manual palpation must be used to assess the intensity of contractions and the uterine resting tone. These methods may require more troubleshooting to obtain necessary information, for example, when a mother with a large amount of adipose tissue in the abdominal area or a mom with multiple gestation. The placement of an internal monitor is an invasive procedure and it requires that the membranes be ruptured. Internal monitoring may be contraindicated in certain scenarios. Internal uterine monitoring provides more accurate uterine activity information. The Doppler converts myocardial movement into sound. The ultrasound should be placed over the fetal back. Use Leopold's maneuvers to determine fetal position. It detects fetal heart rate baseline, variability, accelerations, and decelerations. It also provides a permanent tracing of the recording. The limitation of ultrasound is that fetal and maternal movements may result in a weak or absent ultrasound reflections, therefore your tracing may diminish. The fetal spiral electrode is the only direct measure of the fetal heart rate. It uses the R-to-R interval and translates this into beats per minute. It requires rupture of membrane and some cervical dilation. In a case where there is a fetal demise, the fetal scalp electrode can pick up the maternal heart rate. The tocodynamometer monitors contractions by detecting abdominal wall contour changes. It monitors contractions, duration, and frequency. You need hands-on palpation to determine the intensity and tone. The pressure-sensitive side of the toco should be placed on the fundus. The limitations are that improper placement or maternal fetal movement can result in an unreadable tracing. The intrauterine pressure catheter is a direct method for monitoring uterine activity. It directly measures resting tone, contraction intensity, frequency, and duration. It requires rupture of membranes and cervical dilation. The limitations are that there is a risk of infection and it restricts maternal ambulation. The first maneuver helps determine the fetal presentation or the part of the fetus presenting at the inlet of the pelvis, described as cephalic, breech, or shoulder. The nurse faces the woman's head and uses the tips of the fingers to palpate the fundus of the uterus. If the fetal head is palpated in the fundus, the presentation is usually breech. If the breech, buttocks, or feet is palpated in the fundus, the presentation is usually cephalic. The fetal head feels smooth, globular, and firm. Breech presentation feels irregular, rounded, and soft, and is less mobile. The second maneuver helps to determine the fetal position, the relationship of the presenting part to the pelvis, anterior, posterior, or transverse. This maneuver also helps to determine the fetal lie, the position of the long axis of the fetus, the fetal spine, described as longitudinal, transverse, or oblique. The nurse continues to face the woman's head and places her hands on either side of the uterus. While one hand stabilizes the side of the uterus, the other hand palpates the opposite side of the uterus to determine the location of the fetal back or small parts. The fetal back is a long, smooth, hard plane. The fetal small parts feel irregular and knobby and may be moving. The third maneuver helps to confirm the presentation. This maneuver can also provide information about the descent of the presenting part in the pelvis, such as whether it is floating or engaged. While continuing to face the woman's head, the nurse uses the thumb and fingers of one hand to grasp the woman's lower abdomen just above the symphysis pubis, and notes the contour, size, and consistency of the presenting part. The head feels firm and globular and is mobile if unengaged and immobile if engaged. A breech presentation feels smaller, softer, and irregular. The fourth maneuver helps to determine fetal attitude, or the greatest prominence of the fetal head over the pelvic brim. The nurse faces the woman's feet, and using the first 3 fingers of each hand presses deep in the direction of the pelvic inlet. The nurse then palpates for the cephalic prominence. If the cephalic prominence is located on the opposite side of the fetal back, this is likely that the fetal forehead and the head is in a vertex or well-tucked position.